Hi, good morning all. I'd like to welcome you to this presentation by Dr. Brent Feland. Dr. Feland is presenting on back pain, key signs, symptoms, and exercise modifications. Dr. Brent Feland, MSPT and PhD, is an associate professor in the exercise science department at Brigham Young University. He teaches advanced functional anatomy, pathomechanics, orthopedic impairments, and functional neuroanatomy. Dr. Feland has been a licensed physical therapist for 20 years with a specialty interest in orthopedics with a focus on treatment of the shoulder and sacroiliac joint. Dr. Feland's research interests and professional publications in peer-reviewed journals include stretching and flexibility, aging activity and balance, and neuromechanics of whole body vibration training. He is also a regular article reviewer for the Journal of Athletic Training, Journal of Sport Rehabilitation, and the International Journal of Sports Medicine. Brent is a member of the CSCCa Written Certification Board and is also involved with the American College of Sports Medicine and the American Physical Therapy Association. Let's welcome Dr. Brent Feland.
Thank you. All right, this is going to be a little, I get to use this, that's right. Okay, this is going to be a little bit hands-on for a couple parts. So, unless you're thinking, I don't want to sit here the whole time, I really like you guys to move up a little bit because there's going to be a couple things I'm going to demo up here. So, if you can, get way out of your comfort zone. I'm going to treat this kind of like it's class at school again. And this is kind of fun information. So, I really want a little bit more involvement and discussion when we get talking about some exercises, and I need to be able to hear you. All right, so I'm going to drive you nuts because I can't stand staying in one place. All right. I teach at BYU. I teach orthopedics, advanced anatomy, neuroanatomy. Orthopedics is one of my favorite areas, especially when it comes down to some of the spine and shoulder stuff. So I've done a couple shoulder presentations here in the past. This back stuff, though, a little more complicated. Shoulder relatively complicated. Back, though, sometimes we just can't figure out what's going on with some of the pain that's going on in the back. Okay? So I want you to consider something when we take a look at this slide here. Do you understand the back? So do you understand kind of the moving parts that make up the back? Or do you sometimes kind of ignore the pain and get in the mode of, you gotta suffer through the pain, okay? We gotta just keep moving. Sometimes, though, moving through the pain is gonna make something a little bit worse, when it comes to the back especially, okay? So we're gonna talk about some of the parts, the moving parts that make up the back, so that you guys can have a better understanding of what are we looking at, especially from a perspective that I use when I do anatomy and I take a physical therapy perspective. How do we look at the back? And how do we look at some of the pain that's occurring in the back? Okay? So we're going to go through a little bit of review. Let me ask a question. How many of you have had an anatomy class any time in the last year or two? A couple of you? How many of you had an anatomy class at any point? Most of you. Okay, good. That's what I'm hoping. Okay, so let's just do a quick review. You'll notice up here on the screen here. Let's see. Can you see the red dot? Nah, I should have brought my green one. Okay. You'll see up here that when we look at the vertebrae, we've got three major areas, okay? We've got the cervical, thoracic, and lumbar area. We've got a sacrum, and we'll talk specifically about what is a sacroiliac joint problem, because you guys have probably heard of those. It's a pretty common side of back pain, pretty common cause. The sacrum's fused, though. We just got one solid part there, okay? And then we also have, in that thoracic area, the purple area, one of the things that's really unique there is that all of your ribs attach there. Okay, and then when we get up to the cervical area in the neck, we have 7 cervical vertebrae, but interestingly, we have 8 cervical nerve roots, because the first nerve root actually comes out above that top one, and from there on, everything is named for where the nerve root comes out below the vertebrae. So in the cervical, it gets off count, but in the thoracic and lumbar, they all get back on to count. So if you guys have had an athlete that's had a disc herniation down in the lumbar area, if it's really affecting L3 down in that lower area, then L3 is literally a nerve root that's coming out between L3 and L4. Okay. So we'll talk about what is a nerve root impingement, what is a disc herniation. Let's talk about the spine itself. So we got a vertebral body. Okay, I tried not to make any changes to these notes between when I submitted them and now, so you'll find these will stay pretty much the same. The vertebral body is really interesting. This is actually where some of the misconception of what's the purpose of the vertebral body. The body is really your shock absorber for your spine. Okay, it's not the disc. The disc actually enables the mechanics of movement in the spine, okay? It will help absorb some shock a little bit, but really, the shock absorber is the body. Probably not something that you've thought about before. And when we look at each different region, we have some really interesting, unique differences. In your cervical vertebrae, up in your neck area, your first 2 vertebrae don't look quite a bit like the rest of the vertebrae, especially the first one. The first one's called the atlas, and that's what holds up literally your head. And it sits on the axis, and that's something called an atlantoaxial joint. C1, C2 is atlantoaxial. Really interesting figure on that is literally half of your rotation that you can do from left to right is coming from that one joint segment, okay? The rest of it is then combined movement for the rest of your neck. So when you get a problem in the facet in this one, it's pretty unique. You'll actually notice that, oh man, it's way up here at the very base of your skull, and as you rotation hurts like crazy when you try and move your head. And then you'll know you usually have a facet impingement there within the atlantoaxial joint. You'll also see on these vertebrae right here that there's a right over here on the sides, in the transverse processes, there's a hole. That's because the cervical vertebrae have the vertebral artery that's going up into the head and becoming a major source of blood supply to the brain that travels through that hole right there. And so that atlantoaxial joint, though, sometimes can get some instability in there that's a little bit dangerous. So if you're getting any athletes that are complaining of when you have them going back into extension, or they're just laying down, studying on the floor and looking up at the TV and having spells where they feel like they're getting dizzy, they might be getting a little bit of instability in that joint segment, and it's pinching off that vertebral artery. Okay? There have been a few rare cases out there where you get a manipulation on a table at like a chiropractic office, and then suddenly that was your last manipulation because it can tear that vertebral artery. In the cervical area, one of the things we're going to talk about is why does the cervical move the way it does? So just take your neck right here, bend down as far as you can. You should be able to get your chin almost to your chest. You should be able to look back and literally get your head almost horizontal to be able to look straight up at the ceiling. And you should be able to go side bending and get, within 3-4 fingers of your ear to your shoulder, okay? We also have a lot of rotation. The reason we have that kind of movement in the cervical area is because of the planes of the facets. The facet is how each vertebrae is kind of connected to each other. That dotted line on that picture represents the angle of the facet. So the facet is actually, the facets on how they meet in the cervical area, they are, if you put your hands out in front of you, they're not straight this way. If they were flat right here on the transverse plane, then it would do a lot of gliding. Each vertebral segment would do a lot of gliding forward or side-to-side movement. But the facets are actually angled up. Okay, they're up about 45 degrees. And as we go down further in the cervical, they get a little bit higher, but it's what we call an oblique plane. And that's why you have so much movement in your neck, and you can't match that movement in your thoracic and your lumbar because they go into a different plane as far as the orientation of the facets. Okay, so let's look at the thoracic vertebrae here. Thoracic's really interesting because the thoracic has something unique on the side of the body where it has an attachment point for the rib. The head of the rib actually goes into the body on this little diagram here. This is the head of the rib right there. Okay, and it's going into the side of the body. And then there's also an attachment right here where the tubercle of the rib connects with this transverse process on the vertebrae itself. So there's two attachment points for the rib onto the vertebrae. And so we have something kind of unique in thoracic. Thoracic's kind of stable, especially your upper thoracic is really stiff. It doesn't want to move a lot. So your upper thoracic, in cervical, we're here. Your hands are out in front of you. This is your plane. As you move down to lower cervical, those facet joints start angling up a little bit more. And as we start getting into thoracic, they're almost purely frontal plane. And if you did anatomy or kinesiology class, movements in frontal plane include things like side bending, abduction, okay? Well, that's what happens with the vertebrae. That's why in the thoracic, we don't have a ton of, we have a bit of flexion because the facets will open up, but we don't have very much extension. And I want you to feel this. So you're going to grab a partner, and luckily we got some room in here. So I want you to grab a partner. You're going to put them on the floor, and name again. John. John, come up here really quick. Okay. I want you to go ahead, just lay on here on your stomach really quick. I'm going to show you what you're going to do so you can actually feel this. You probably felt this before. We have something that we call a spring test when we're checking on the spine. I can go into his lumbar, just put the spinous process right here in this crease in my palm right here. In the lumbar area here, I can give a little pressure, and don't go straight down because that's not the way the spinous processes are angled. You're going to actually go down and forward a little bit. So I can go into his lumbar area, push a little bit, and I feel those lumbar vertebrae go down and just pop right back up. Okay? As I go up his spine, there's good movement there, good movement there, good movement there. Now you're going to suddenly get to where you have this kyphotic curve in the upper thoracic area, and you're going to suddenly feel that gets incredibly stiff and just won't move. Okay? So I want you to feel that on someone, and we're going to talk about it because that's what helps. It's the facet orientation that makes it so it can't move that way. Okay? Just feel that on someone so you can feel how stiff that gets. If there's anybody in here that has a little bit more of a thoracic curve, you're going to feel it even more. And be a little quick when you push down on it. Don't be nice and slow moving. Just nice little quick push that's just going a half inch down. Yeah, you want him to keep going? Yeah, you'll be able to tell it gets really stiff. How many of you have used a foam roller to roll your back on the foam roller? And one of the things that will happen, you'll get those ribs to actually cavitate, which is will actually get them to move and shift. And that's, sometimes the big pops that you're feeling in your cervical area is actually going to be your ribs that are cavitating there at the joint that they attach to. Now, usually ribs, when they attach into the vertebrae, are pretty stable, though, but sometimes those ribs are actually from acute pain, like something where somebody moves and goes, oh man, what is that? It's something right in between my shoulder blades. It's usually a rib dysfunction, okay? It's not usually, a lot of the pain in the back stuff is very rarely muscle strain. It's usually mechanical vertebrae problems that actually happen, and a lot of that will occur with the facets. So in our thoracic area, the upper thoracic has a decent amount of flexion, has pretty good lateral bending, side bending, and a semi-decent amount of rotation. The rotation gets a little bit better as we move down through the mid part of the thoracic area. But it changes a little bit. And by the time we get into the lumbar area, we start getting some really big vertebrae. The bodies on these things are really huge. But notice our disc sizes don't really change. It's one of the things that points to the fact that the body itself is really kind of the shock absorber for your spine. That's why it anatomically changes in its size. All of your weight in your upper body and all the force coming from your lower body is now having to transition in that lumbar area. And that's why we see these being really large vertebrae. Not only that, the spinous processes have to be pretty large. We got some really big, deep low back musculature that attaches onto those transverse processes and the spinous processes. I want you to take a notice of the discs, though, that are in between the vertebrae. One of the things that makes the lower disc more prone to having problems, so the most common disc problem in the body is the L5-S1 disc. Notice if we have the vertebrae coming down, it suddenly has to take this curve, almost like we're extending in the low back. And does anybody know, we're going to use this term a little bit here. When we have this curve that goes towards the front back here, we call this a lordosis or lordotic curve, right? And then up here in the thoracic area where we curve out this way, you've seen some people sometimes have a big thoracic curve. We call it kyphosis. That's called a kyphotic curve. Okay, and in the cervical area, we have a lordotic curve again. Well, that lordotic curve in the low back, notice what it does between L5 and S1. L5 and S1, we have this angle at which the vertebrae sits on that sacrum. And so we have the potential for having a little bit more shear. We also have a lot of compression that can occur here at this disc. So it tends to get quite a bit more abuse. And we're going to talk in this presentation, what are some things that actually put more pressure on an intervertebral disc? So when we look at the vertebrae from a transverse view, looking down the vertebrae, we can actually see the facet joint right here. And the facets all are sitting at a particular angle. That's what makes it so that there's a certain type of movement that occurs in the lumbar, a certain type in the thoracic area. And we'll see here, up in the upper lumbar areas, like L1, L2, we generally have somewhere around a 25-degree angle if they take an average. Oftentimes this is really more commonly up in the 30s, though. And as we get down here into the lower lumbars, into the L5-S1 segment, it's going to be almost sagittal plane, meaning that angle is going to be greater than 46 degrees. It's going to be closer to 70, 80 degrees almost to the front. So that's why in the lower lumbars you can actually do quite a bit of flexion and extension. The problem is that change in movement does put a lot of stress on the disc. And that angle that's identified here on this picture right here, it should be relatively equal from one side to the other. Sometimes we don't get vertebrae that form quite right, and those angles are off. One side will be 5, 10 degrees different than the other side. And that's a unique condition that we call tropism, and can be a cause of kind of chronic back pain that we can't quite identify. All right, so we get this question: what kind of back pain is your athlete actually experiencing? Okay. So there are a lot of possible causes of back pain. How many of you currently have periods of time when your low back's hurting? Okay, should be at least half of you, because it starts to become quite common. Okay. What I'm going to talk about in this presentation is we're going to go over a little bit of what's a rib dysfunction and how could you identify that, and then what is the difference between a sacroiliac joint dysfunction, and then what we see the most out of a lot of our athletes is this generalized low back pain. Okay, so in order to kind of understand how we're going to categorize this, let's talk about pain as far as how long has it been there. So we have what we call acute back pain, which means acute means that's rapid onset. It just recently happened. Okay, that's generally we consider the acute phase somewhere up to about three weeks or so. The subacute phase is when it's gone longer than that, but it hasn't become a chronic long-term problem. And so that's generally up to 3 months. Anything beyond 3 months, some doctors won't really consider it chronic until it's been longer than 6 months. But anything longer than that is getting into a chronic pain cycle. And the chronic pain cycle also has a lot of other negative factors to it. I mean, we're getting this chronic inflammation, we're getting abnormal amounts of muscle tension, muscle activation because of these abnormal mechanics that are occurring. And that's starting to put it into this kind of cycle of negativity there. If we get abnormal muscle tension, we get reduced circulation. Reduced circulation actually impairs healing. And it can cause some ischemic-based pain in certain situations. And then you also have the problem of psychologically, what's it doing to the athlete when they keep having this chronic pain? And now they're going to start guarding their movement. Okay, so is it potentially serious? Common question I always get is, my back's been hurting. When do I know that I need to go actually see the doctor on this? Okay, so there are a couple indicators that do happen that are, wow, you should get in and see the doc right now. Okay, so one of our biggest concerns with back pain is it affecting a nerve root? Okay, are they experiencing when they're sitting down or standing up this leg pain they can't explain? Okay, leg pain could be up just in the quad, could be in the hamstring, could be just through the glutes, or it could be the fact that they're starting to notice their tibial muscles, like tibialis anterior, starting to really ache, or the top of their foot going kind of numb. Anything below the level of the knee is indicating a more significant nerve root involvement. And so we have to delineate, that's kind of specific to nerve root, but we also have some other more serious conditions that we call non-mechanical pain, okay, or what we call non-positional pain. Okay, non-positional pain can indicate an internal organ thing, but let's talk about this. This is what normally goes on with most of our athletes here. This is mechanical pain. Mechanical pain means we have a vertebrae sitting on a vertebrae, and they have to move a certain way. Okay? If they move the right way, there's usually not any irritation in the joint. But if they get stuck and they can't move quite the right way, and we'll talk about why that can occur, then the mechanics are thrown off. all of the muscles surrounding there in the vertebrae, there's a lot of ligament and there's a lot of little tiny muscles that help control actual motion in the vertebrae. Okay? If it's not moving right, they start freaking out, basically. And we get that spasm and that real big uncomfortable feeling that's right there in the spine because the mechanics are not working right. Okay? So that damage could be a ligament or muscle problem. Oftentimes it's connective tissue, facet joint very commonly. It could also be that you have an athlete that's already, even though he's only 19, even though he's only 20, he's already getting early what we call annular changes, which is the outer walls of the disc itself. They're starting to shift and change. And that outer area is highly innervated, and it can cause some pretty significant amount of back pain. Okay? So this stuff usually gets worse over the course of the day. They'll normally wake up in the morning going, oh, okay, that's not feeling too bad. And as they go through activity in the day, it starts aching on them more. Or if it's an acute back pain type problem, they could have something that's just immediately grabs them, and they're like, oh, this is just hurting me like crazy. Most of you have experienced this in the neck. How many of you have ever gotten out and twisted your head and gone, oh man, what was that? Like 6 hours later, 12 hours later, you're suddenly like, not only what was that, what the freak? I can't even turn my head this way, but I'm kind of okay going this way. Okay, that's a classic facet impingement that usually occurs in the neck. You'll notice it takes a week or two to get back to normal off that, but that's usually a facet problem, and that's definitely what we categorize as mechanical back pain. Okay, so usually mechanical back pain, the classic component to say, is this mechanical or not? The classic component is to go, is there a position you can move in that hurts like crazy? And is there a position you can move out of where your pain is reduced a lot? If it is, that's mechanical back pain. Because the mechanics have a position where it hurts a lot more and a position where it does not hurt as much. Okay? Where we really get to a concern is when we get to non-mechanical back pain. Okay, this would be, luckily you guys won't have to deal with this too often, but it does happen. If you've ever had any athletes that have had like a kidney stone, this is a good example of non-mechanical back pain. It's also what we call non-positional pain, meaning that pain is there and no position makes it better or worse. So if you've known anybody that's had a kidney stone, they start doing, sometimes we call it the floppy chicken. They just start moving all over the place because they're trying to find some position that helps them feel better, and they can't do it. Okay, so we can get these random pain patterns that will occur. Now, that is a case of what we call referred pain. Referred pain is always the term that's used when we talk about internal organ problems. So on that right column, it says an internal organ problem, like a kidney stone, or you guys know the radiating pattern for like indicators of angina or heart attack. Okay, left jaw down left arm, mediastinum in the center. Those are referred pain patterns. They're problems with an internal organ being referred out to an extremity. And I don't have time to go into the why does that happen. There's a reason that it happens, and some pretty good theories as to why that occurs. But one of the other problems is with neurologic-based pain, that's radiating pain. How many of you have ever had a disc problem that radiated down to your leg, or radiated down to your arm if you had a neck problem? Anybody in here? A few of you, okay? If you get a disc pinching on a nerve root, that nerve root specifically, that pattern for whatever that nerve root innervates is going to have pain down it. And that'll be random. Sensory always comes first. If you start getting motor weakness, like suddenly noticing you can't go up on your toes, get into the doc pretty quick, okay? That's if you've been kind of ignoring the fact that part of your foot keeps going numb or you have these dull, vague, achy pains just because you don't want to have to deal with it. You start noticing motor weakness. Motor weakness would be the one key thing I say, you've got to get in. You've already had, that's starting to get significant nerve compression if you're getting motor weakness. Okay, these, we're not going to go over these, but this is just referred pain pattern areas. So there's a lot of internal organs will refer out to a very common site within the body. That stuff is non-positional, and it's dull, vague, achy pain that is really hard to describe. It's just this area, and it just aches and it hurts. And it's very different from mechanical back pain that has a position where, oh, that's grabbing me like crazy, that hurts. Oh, that's a lot better. Okay, dull, vague, achy pain is something to get right into a doc. So when do we say see a doc? Well, athletes, if they start having any pain issues, they should be reporting to the doc anyway, right? Because we've got to get that documented. But serious issues, like when you're dealing with yourself or your family members, do they have radiating pain? If they have radiating pain, especially below the level of the knee, that's usually a nerve root that's truly getting irritated. Mechanical pain, like me just twisting and pinching a facet in my back, it may hurt like crazy in my back, but it can commonly radiate out into the hips or into the back of the leg. Okay? So going down lower than the level of the knee is a pretty key indicator. Pain or numbness in the saddle area. The saddle area is right through the middle. Like if you're sitting on a saddle, what's touching the saddle? That's the saddle area. That's pretty significant there. Also, noticeable and explainable changes in micturition or urination. Okay, if they really notice a problem there or a problem with control on there, in our athlete's age, that's not normal at all. Okay, that's an immediate sign to get in. All right, let's talk about this. What's a rib dysfunction? Most of you have had this. How many of you have had a little nagging, aching problem right there in between your scapulas? And you notice it either with rotation or sometimes even taking a breath will hurt. Okay, oftentimes it'll go away just on its own. You just got to get the inflammation back down. That rib will settle back into its joint the way it should be. But it can be a source of just nagging acute pain. It's not like terrible, but it's bad enough that you're like, oh man, that's just aching. And you can find the spot specifically. Okay, we know when somebody has, it's kind of unique, but we can, when somebody does have a rib dysfunction, it affects the iliocostalis muscle that goes right in the trough across there. And so when we're palpating someone, just to try and find the problem, you guys will feel, let's see, anybody in here have like mid-back pain going on right now? Like, you think you might have a rib issue? Like in between your shoulder blades? Come up here real quick. What's your name? Jason? All right, just lay down here on your stomach real quick here. So usually what we find, if we take our hands, and you can find the spinous processes, you know where those are, and then you just go over to the side, about 2 fingers to the side, 2 fingers worth to the side, because that's right where the rib starts angling up again, and it's not the deep trough, but just to the side. And so when we take our fingers and we palpate right through there, let's find on him, it's, oh, right there? Yeah. Okay. So you can actually feel this hard band that's there. It's almost like a guitar string that's stuck under there. And so when you get used to being able to just palpate, you just literally just shift real quick across the side there. When we have a rib that's out, all of a sudden there's this really nice, hard, tight, tense band that's there. Okay? And it causes that iliocostalis muscle to be really tense and tight. Okay? A little bit harder when you start dealing with people that have a lot of muscle in their back. Thanks. So he was hoping I'd jump on him and manipulate him. Most rib dysfunctions can be, if you take it to the trainer or the chiropractor that's there, half the time all you need to do is just get pressure on that, and it'll be in either an anterior or posterior rib. dysfunction there. But there are certain rib dysfunctions that exist without back pain. In your runners, you're going to find this quite a bit. If they start having a lot of neck, upper extremity base pain, they're running and they're like complaining at the end that, man, this is just hurting and aching up here. They could be upper extremity breathers, and they could have rib restrictions that are keeping them from breathing correctly. Okay, so there are actual patterns that we follow with the ribs when we follow breathing. I want you to, on this one, with the rib movement, just want you to kind of understand this one. So we have two kinds of movement that are described. There's an orthopedic guy named Greenman. He's not around anymore, but he had some really good material that was out. So in the upper ribs up here, if we have someone take a big, deep breath in, we find that the ribs kind of come up and elevate this way. So it's kind of like a pump handle, okay? So the ribs come up and down this way a lot more in the upper 6 ribs that are here. And then the lower 6 ribs, it has some pump handle, but it also has a lot of what we call bucket handle, which is out to the side. So these lower ribs will expand up and outward this way. Okay, and then the very last 2 ribs, which are way down here in the low back, they're not attached to anything. They're what we call floating ribs. They have kind of this caliper motion where they just open up. Okay, so we can actually assess a rib for its motion. And what's interesting is when a rib gets stuck, we can actually find rib movement. We'll follow like T6, have them breathe, like, oh, is it moving or no? Okay, T6. T5, moving or no? And once we get to the one that's stuck, nothing above it moves. Okay? They'll take a deep breath, and it just won't move up the way it should. And so then we can actually manipulate that with their breathing patterns and get those ribs moving normal again. Okay? So we always have to assess rib motion when we're getting somebody with something that's a breathing-based dysfunction with rib motion. Torsional movements can cause some really unique type of pains. The ribs do torsion. So torsion means what? Anybody know? Means twisting. Yeah. So the ribs, though, when they're coming out the side, when ribs twist, they're kind of twisting inward or outward. Okay? So if I rotate over to the right, I'm going to have one rib turning in and the other rib turning out. So on my right side, if I go like this, I'm going to have my ribs going basically like this, following me as I turn this way. Okay, so they can actually get stuck in that torsion movement, and that can cause some pretty unique pain that will occur there. Okay, some of the unique things that happen with those of you that have athletes in contact sports, you can get compression of the ribs, which then can really commonly cause this radiating pattern that goes along the ribs towards the sternum. Okay, so if they're having chest wall pain, it may not be. They could have some pretty significant chest wall pain here, and it's from this compression and then release, and it didn't quite ever go back to normal position. And so it can oftentimes be referred to as being pretty significant rib radiation pattern or pain with no signs of any sort of fracture that's there. Okay, it is one other possibility that does exist with a rib problem. Okay, so last thing I wanted to mention here was with the ribs, a first or a second rib. That's way up here. In fact, I'm going to have you guys try and find this because you'll realize how achy this is. So get a partner, okay, and let me see, what's your name? Kimball? Kimball? I can't hear. Clement. Okay, come on up here, Clement. Let me show you what I'm going to have you do here really quick. I'm going to have you guys find the first rib because you're going to realize that, go ahead and just stand right here. Go ahead and stay right there. Perfect, because you're taller than I am. All right, so you find the trap. Everybody knows where the traps are. We get the very front edge of the trap right here. I'm just going to pull it backwards a little bit, and I'm going to come downward right here, and right there, there's his first rib right there, okay? Now, if I get a little bit of pressure on there, that's pretty uncomfortable, isn't it? Okay? That first rib, though, is going into that first thoracic vertebrae, So neck movement becomes really, really painful. If we get in there and manipulate that just a little bit, I get a little extra pressure on there. Now turn your head to the left and side bend to the left. That starts to be painful, doesn't it? Okay? It can cause pretty significant neck pain. So oftentimes, upper neck pain, you have to really distinguish, is it really a cervical or thoracic problem, or is it actually just a rib that went out? It's much more nagging than the ones that are in between the scapula. Okay, when we get into that more around that T3 to T6, T7 area. Those are just the kind that are just like, oh, what's that tight knot right between my scapula? First or second rib, pretty significant neck pain, but you'll notice it's right down here around the trap. I want you to try and find that just so you can see how sensitive that is. Pull the trap back, push down, you'll feel the nice hard rib right there. You got to get your fingers back and down. Okay? Yeah. Talk to the person you're doing it to, because this is not a super comfortable thing to find. And with some of you guys that have abnormally large traps in here, you're going to have to really pull that back a little bit. You should be able to find that hard rib as your fingers go down. Okay, it's your fingers in the front, so when you pull the trap back, your fingers in front going down. So clavicle, it's going to be back a good 2-3 fingers from where the clavicle is. And you got it on them. It is very, very sensitive. Okay? Yeah. All right. So when we bring this back, there's your first rib right there. We oftentimes will get a first rib that will separate, will come up a little bit more. And so when you actually palpate, if you get good at being able to find those two, you'll actually feel a height difference between the two. And the side that's really sore will be sitting up higher than the other side. Okay, here's something to consider. You're going to have to take this up with your trainers. If you have someone that is constantly getting a rib problem in the same area, in their mid-thoracic area, and they seem to be repeatedly getting that. They're getting it 1 month, and then suddenly a month later, they're like, oh, I'm getting this again. And then they just keep getting it over and over. It's very often musculoskeletal imbalance. They're having some abnormal tightness, serratus anterior, lats, some of their upper deep muscular, iliocostalis-based stuff. If you start working on a lot of thoracic mobility and rotation movements, and especially like, medicine ball movements, doing some rotations, doing some foam roller-based work, oftentimes you can start getting rid of those. A lot of thoracic immobility leads to abnormal muscle tightness patterns around our thorax, and that leads to a particular spot in the rib, or section of ribs that tend to keep coming out. All right, here's my favorite topic, because this is something that I treat a lot. It's called the SI joint. How many of you have heard of this? Sacroiliac joint. Okay. Sacroiliac joint, pretty common. Now, let's talk about what are the parts of this that make an SI joint dysfunction. To call it an SI joint dysfunction is actually very generic, because there's two main components that could be a problem here. It could either be the innominate, which is this part of the ilium, so one of your pelvic sides meets up with the sacrum right here. Okay? And then this other pelvis side, this other half of your pelvis, meets with this side of the sacrum. Okay, so each side of your pelvis works independently. That's the reason I can walk. That's the reason I can put one leg into extension and my other leg into flexion. I'm going to get them shifting and doing a different thing. Okay, but that sacrum's in the middle, and it's kind of stuck doing some other motions that's there. So when we talk about an SI joint dysfunction, we have to figure out, is it an ilium problem or a pelvic problem, or is it a sacral problem? Okay? Those are two very, very different things. Unfortunately, what we normally find is that a lot of your trainers are really good at finding the iliosacral problem. That means it's the ilium or the pelvic part that's kind of stuck. Because when an ilium is out of position, that's very easy to catch. Okay? We can identify that really quickly. We usually use 3 little landmarks here. We use the top of your ilium, which is called the iliac crest, okay, and we can look at height differences there. We use this pointer right here in your hip, which is called the anterior superior iliac spine right here. And we can also use a similar spot right here in the back side. And we can kind of tell, is this side rotated compared to this side? Or is this side rotated compared to this side? Okay? Or is one side up higher and one side up lower? We never assess it while we're actually standing here. Once you're standing, you're compensated, is what we call it. I mean, you've made adjustments for it being out of position. Okay? So we always do this when you're laying down on your back, because then you're not weight bearing and you're not compensating for any of the misalignments there. And then we compare those landmarks. Okay? So ilium problems, really easy to figure out. Obviously, if my ASIS was higher, my iliac crest was higher, and my PSIS right back here was higher on one side than the other, when I lay down, what's the leg length going to look like? It's going to look like it's shorter on this leg, right? Because everything on this side's higher. And that's a pretty common problem for an ilium, is what's called an upslip. Okay? Pretty common one to find. But it's also very easy to fix. Okay? Ilium problems are very easy to fix. We can do some really quick muscle energy techniques or some quick little leg jerks like in an upslip. Downslips even happen. They're kind of rare, but they do happen. Pubic dysfunctions are another thing that can happen. But those are really easy to fix. And they will cause, so one of the classic signs, somebody who has an SI joint problem, just ask them, go, where's your back hurting? And if they point down here where you get onto your bony parts right down here, where the PSIS is, that's usually an SI joint dysfunction problem. So you guys have noticed this on an athlete, you can see actually 2 dimples down here on your low back. That's right around the area where the PSIS is, or the posterior superior iliac spine, the very back ridge of that iliac crest there. Okay, that's one of our landmarks that we use. Okay, so being able to assess an ilial problem, very unique. They will usually point to one side or the other. Now, the really weird thing about SI joint problems, what side they say the pain is on has nothing to do with what side the problem is on. Okay? Never trust the pain. When we do an assessment, I don't care where they say it hurts. I have to trust my mechanical tests that I'm going to run them through in order to be able to evaluate what is the problem that's actually going on. Okay? It's really weird. It's kind of random, but we never trust the side of the pain. Okay? In the lumbar area, though, that's a little bit different. When we get to lumbar issues, that could be the side. And here's the part where I want you to challenge your athletic trainers or your physical therapists that are working with your athletes. If you have an athlete, especially like a track athletes are like, well, those of you that have worked with them, they're like the most needy group that you're working with. They got to be massaged like every 5 minutes, okay? But when they're kind of more in tune with how their hips and their pelvis works, though, than pretty much any other athlete. I mean, they know exactly how their legs should be feeling and their hips should be feeling. But if you have someone that's constantly coming back over and over, oh, you got this again, let's fix it. Oh, you got this again, let's fix it. The main problem isn't being found. You're just fixing one of the secondary problems, and it's only holding for a short bit of time, okay? So what happens, this is totally mechanical. SI joint pain, totally mechanical. The only time we get, especially in your age group, the athletes, it's completely mechanical. That ilium shifted up, it's stuck in that position, let's get it back down. Okay, it got rotated, it's stuck, let's get it out of the rotation. Sacrum, though, is a much more complicated thing to assess. And that's the one piece that I've found as I go around within watching how people treat SI joint. They don't know how to assess the sacrum. Okay? Give your trainers a challenge to go through some continuing education and figure out how to actually assess the sacrum. Sacrum is definitely more complicated. But a lot of times, if they're having to keep being treated for the same thing over and over, the primary problem is not being found. And oftentimes it's the sacrum that's actually the problem, and it's pulling the pelvis out of position. Okay? You can also have a lumbar problem that pulls it out of position too. With the sacrum, though, one of the things, women are a little bit more prone to having SI joint problems, okay? There's differences in how the pelvic outlet is in women versus men. Also, especially women that have already had, if you have any college athletes that have already had a kid, they've gone through quite a bit of stress on that SI joint, as well as a period of time where they also had relaxin being out hormonally to be able to make that joint lax in order to be able to give birth. Okay, so women do have a tendency to have a little bit more chronic problems with SI joint. And later, with SI joint-based problems, they can actually, you can get a lot of pain that's not truly mechanical. You can start getting, because the problem's been there for a long time, start getting some chronic inflammatory-based problems that are there. And those end up having to be treated a little bit differently. Okay, so let's go over this. Everybody stand up real quick. Okay? With the sacrum's kind of unique. So, as I bend over this way, what do we call that in the spine? We call it flexion, right? Okay? So as I bend over this way, we call this flexion. What happens to my lordosis when I do this? Go away or? Yeah, it's going to go away, okay? If I go into extension, what does my lumbar spine do? A lot more. It extends, and what happens to lordosis? Increases, okay? Now, here's the thing. Kind of use your hand here. As I flex, my sacrum's going to come backwards, okay? So think your lumbar spine's kind of going forwards, but your sacrum's going to come backwards, okay? Now, so here's what I want you to do. Put a partner on the floor real quick. I'm going to have you palpate their sacrum here. So let me come on up here real quick. What's your name? Jared. Jared, have a seat right here. Here's what I want you, actually lay on your stomach for me. Here's what I want you to do. You'll be able to feel this movement. We can actually assess this. So you're going to take your hand right here, and not on the low back, come right down here, right over their sacrum right here. Now what I'm going to have him do is I'm going to have him take a really deep breath. Go ahead and take a big deep breath and follow that sacrum, and then let all the air out. Take a big deep breath again. Notice when he takes a big deep breath in, sacrum comes up and back. And when he lets all his air out, the sacrum drops down and in. Okay? When he takes a big deep breath, look at his back right here. Bring it up. What's he doing in his back when he's on the ground here? Is he flexing or extending when he takes a big deep breath? Because his back's coming up. So it's flexing his back. Okay? But as he flexes his back, the sacrum comes back this way. And in the sacrum, this is almost like extension of the sacrum. The sacrum almost always does the opposite of what your lumbar spine does. Okay? That's the mechanics of how the sacrum works. It's almost always doing the opposite. Okay? I just want you to be able to feel that because it's a surprising amount of movement that'll actually occur. Okay? Go ahead and just do that real quick on someone. All right, so if someone has a lumbar problem, especially a lower lumbar problem, it will eventually affect the sacrum, okay? You could have somebody that keeps going in for an SI joint problem, and they're going, this is still hurting me here. But when you really assess where their pain is, one of the things that's really unique about lumbar problems is it hurts right here in the lower back, and it's not down here at the bony part on the PSIS. It hurts actually up here in the musculature of the lumbar spine. Okay, so there's really definitive difference there between when somebody comes in and they're like, man, it's hurting up here in my lumbar area. It's like, crud, that's not going to be a nice, easy problem. Okay, because now we're having to deal with the mechanics of the lumbar spine, which now just made things quite a bit more complicated. Okay, but lumbar spine having a problem will eventually pull the sacrum out of position. And then you have this SI joint problem that could be just a secondary issue because of a lumbar issue. Okay, so you have to be able to kind of tell what's going on. Now, this is going to lead to us kind of talking about what we call pelvic neutral, okay? So everybody stand up by your desk here. We're going to do pelvic neutral. I'm hoping that some of you have taught pelvic neutral to your athletes before. How many of you have heard of this principle before? I'm hoping a lot of you, okay? Pelvic neutral, what is it? It is the area that's in between going into flexion in your spine and too much lordosis. It's that midpoint that's just the right amount of lordosis, okay? So it's not a rounded back. And you'll notice your pelvis right here. If I posteriorly rotate that as far as it'll go, you'll feel your low back will flex. You'll feel you have to tighten up your abs to get that up there. Okay, so what primary muscle groups can we use to cause posterior rotation in the pelvis? Because in order for me to get posteriorly rotated in the pelvis, I have muscles that'll posteriorly rotate. My abs attached to my pubis right here. So when I tighten up my muscles, just relax. If I try and do like beer belly thing, okay, you'll notice as soon as you do that, your pelvis drops into anterior tilt. Tighten up your abs, and you'll feel your whole pelvis rotate posteriorly. Okay. The other thing we have that can cause a posterior pelvic tilt is your hamstrings attached to your ischial tuberosity. So if your hamstrings are abnormally tight, they'll keep your pelvis posteriorly rotated a little bit more, okay? Or you can just contract them to help posteriorly rotate your pelvis. But really, when we try and control pelvic position, when we're standing here, we're using abs, okay? Abs contract, they pull up on the pubis, and we can get this up here. Pelvic neutral, though, is that area in between. This is not a movie, like, the Dirty Dancing movie. This is literally a position you should be teaching someone. When we take back pain patients in their 30s, 40s, and 50s, this is the first thing we teach them. Okay, I want you to find pelvic neutral, which is not anteriorly rotated too far, not posteriorly rotated. It's right in the middle. Now contract everything and hold that position. And now, even when you're reaching for laundry in the washing machine, even when you're vacuuming, I want you thinking pelvic neutral, hold it, and now do those movements, okay? When you do core training, that should be the number one thing you're emphasizing before they start any other core exercises. Hold pelvic neutral. Okay? So you got to be good at finding that and hold it. In order to be able to hold it, though, you really should be able to do transverse abdominis activation. So we're going to find the middle line right here. Okay? Now, here's something kind of interesting. I'm going to have you sometimes this is easier to do when we're laying down. But you'll notice, if you find your little hip pointer right here, that part right where you got the SIS pointing forward, pretty easy to find. Nice hard bony part sticking out into the front here. Cross over that. Sometimes you have to pull your belt down a little bit more to cross right over that, right at the top. So right over the front of it and right over the top, you're on your lower abdominal area right there, okay? Now, here's the deal. If you can, when you're laying down, even in standing up, you can get decent at this. if I ask you to contract your abs, you're going to feel right below that ASIS, there's some musculature right here on this lower side. So if you take your fingers right over that ASIS right here, if I ask you to contract your abs, you're going to feel that muscle push your fingers out right there. Okay? How many of you can feel that? You should be able to. If you're right in the right spot, right over that bony thing, go over and then press your fingers down and in a little bit. If you contract your abs, it should push your fingers right back out. Okay? Now, here's the thing. Can you contract your transverse abdominis without pushing your fingers out? Okay, that means you have an ability to actually contract your transverse abdominis or your TA. Okay, so can I suck my gut in and not get that pushing my fingers out? That's a good little exercise to practice in order to be able to get your transverse abdominis activated without overriding transverse abdominis by just trying to supercompensate by contracting all of your abs. Okay, what we usually find in people that can't hold pelvic neutral and truly do a good job in maintaining good pelvic neutral is they can't contract their transverse abdominis in time. It comes in kind of last because they're too used to taking the wrong strategy of contracting all of their abs. Okay? Transverse abdominis is a key player. When you're laying down on the ground, just when you're bored, do that activity. Okay? Put your fingers right over there. See if you can suck your gut in without firing off your rectus abdominis and your obliques. Okay, have a seat real quick. We'll have you doing a couple things here. If I were to ask you, what do you think the most commonly tight lower extremity muscle is? What would your answer be? Huh? Quadratus lumborum? Quadratus lumborum, definitely common. Psoas major, okay. Rectus? Okay, yeah, rectus, pretty common. Psoas? Okay, that's good. A lot of people will say usually hamstrings, right? Which is not. It's your hip flexors. So what are your two hip flexor muscles? Two major ones. Okay, psoas major and... What are you saying? Okay, so tensor fascia latae, yes, but the problem is it's on the side, so it's not like it's hip flexion and abduction at the same time, right? So, so it's called the iliacus. So you guys have heard the term iliopsoas, right? Okay, that's the iliacus and psoas major combined. They both cross over the pubis. They both attach right onto your lesser trochanter of your femur. The other one would be your rectus femoris then after that, which is one of your quadricep muscles that happens to attach right at your anterior inferior iliac spine. Okay? But your hip flexors are the most commonly tight muscle group in the lower extremity. And if the hip flexors are tight, that means you're going to be put into a little bit more anterior rotation than you should be. And that ends up affecting both lumbar lordosis and also usually complements more of a weaker abdominal state than normal. Okay, so this neutral pelvis is a really important position that we need to be able to hold. Okay, so will weak abs increase or decrease lordosis? It will increase. Why? Because it causes what? Anterior pelvis, anterior rotation in the pelvis, okay? And when that happens, we go into more lordosis in the lumbar spine, okay? All right, this is something I just want you to try, because if we get somebody that's coming to us and they're saying, man, this is just kind of irritating me over here, and you know they've seen the trainer and it just doesn't seem to fix it. There are a couple really subtle exercises that you can give for SI joint. Having your athletes do these, really simple for them. These are not aggressive, what we would deem to be like strength training type exercises. But there's a couple really subtle movement. Since SI joint, especially in your college-age athlete, is going to be predominantly mechanical, we just need to get that just kind of moving just a little bit. So these are subtle exercises, super simple to do. They don't take much time, but you can really make a big difference in their pain, we found, by just having to do it within a week or two. If they're just throwing this in for a few minutes, generally their pain problems go down big time. Okay, so if it is SI joint, it'll go down. Okay, so let me have someone come up again. Want to come up again? Thanks. All right, so I'm gonna have you lay down here on your back. Yeah, so Clement's gonna lay down here on his back, and so a couple real simple exercises. You guys see that up on there? All right. Okay, so we're gonna bring legs up here, and we're just gonna have the knee and the femur bent to 90 degrees. Okay, I'm gonna go into his back area here, and I want him to be in pelvic neutral. Okay, so when I put my hand under here, I'm gonna feel, is his back pressing into the floor? Is his lumbar spine pressing into the floor? If it is, then he's in too much flexion. Okay, I don't want it touching the floor. Okay, so go ahead and kind of round out your back. Okay, push that down on the floor. Okay, now come back up a little bit. Come up a little bit more, go into a little bit more extension. Okay, down just a teeny bit, right there. Hold that position. So first thing I ask him to do is hold it, and what he's gonna do is he's gonna contract his abs. My hope is that he could do one of those, hold here, and figure out, can he contract his TA first in holding? Okay, when we hold the abs, or hold pelvic neutral, we want that transverse abdominis activated first. Okay, so if he can hold that position, now just keep that position right there. Two really simple exercises. First one is going to be, I'm going to have him hold that position, pull this leg up, put your hand around this leg, put this leg down now. Okay, now again, make sure you have that back just slightly up off the floor, but not pressed into the floor. Okay. Hold that position, and now as you contract holding this position, lightly try and push your leg down towards the floor, but you're not going to let it with your hands. So, yeah, it's just an isometric contraction, okay? You're holding abs, you're just pushing with a little bit of pressure this way. About 5 to 6 seconds, that's it. And then you relax, do it 5 to 6 seconds more. Just have them do it 10 times really quick, okay? Do the other side. What it does is somebody who has an SI joint-based problem might, in this one, feel it gap just a little bit in the SI joint. It's going to cause just a little bit of motion at the SI joint. Okay, and there's a small range. We can go up a little bit. Go ahead and relax. We could go up to here a little bit more. If it starts causing him to flex his back, you're too far. Okay, so there's just this little range from. Go ahead and let go here, Clement. Somewhere between here to here. That's the range that all they need to be working that in, okay? The other one is both feet on the ground here. And now we could do two things. You could either just put a TheraBand strap around or a surgical tubing cord around their legs, and we have them do the same thing. Go ahead, get back just up a little bit, hold pelvic neutral, and now what I want you to do is push your legs out. We'll let it move just about like 6 inches. And just hold, relax, go right back in. Okay, good, relax now, and go right back into here. Hold pelvic neutral, and now just slightly push out. And we don't want a lot of resistance, just enough to get the SI joint to gap. Same thing, medicine ball in between the two. Okay, they do the exact same hold, and now they press in while they're holding pelvic neutral. It gets the SI joint to gap again. Okay, super simple exercise. It just gets a little bit of SI joint movement. So if they have common complaints, really easy exercise that emphasizes pelvic neutral, and we get the femur moving, which influences pelvic motion. Question? Okay, so that's gapping at the pubic joint is what's going to end up. So rarely, every now and then you'll get someone who will pop like in the back, but usually the pop is from the pubis. If I had him contract super hard, especially if we got that little pop we just did, okay, that's his pubis that actually pops. Pubis is actually a joint. I mean, it shifts and it moves. Someone who has an SI joint rotation, oftentimes they will, if we finish off with that one, they'll get this huge pop and they'll think something went way wrong. And it's not. Sometimes you can just stand on the ground and just squeeze in this way and get your pubis to pop pretty good. Okay? It's a good sign, though, that your pubis was not quite centered, though. But that's a pretty common thing to find. Okay. All right, then, so those are the three major ones that I would do right there. The other one, I'm going to have you guys lay down and do this. I'm going to have, cross your leg here. This is what we call, anybody heard of Faber's test? You guys heard of this? Faber is not the name of a person. It's actually the acronym for flexion, abduction, external rotation. It's a figure 4 test. Cross your leg. What you hope to see from your athlete is that this tibia on the lower leg will be parallel with the floor when you do this test. And you don't want them over-rotating here to try and make it look like it is, okay? If this leg is sitting up here, then we have a little bit of external rotation tightness that's going on. Yeah, and you do, yeah. Okay, let's go to this one. Do your other leg real quick, okay? And even more, a little more on this one, okay? Now, this external rotation becomes hugely important from what I've seen for a relationship between that and some of our pelvic-based problems for SI joint. So I would have him working really aggressively on getting external rotation range of motion back in there. I want that Faber's test to be pretty close to normal. And I'm going to see a reduction in his possibility of flaring open or having a innominate sacroiliac problem on there. Okay? All right, so do that. Check yourself really quick. I want you to see if you are really tight on a Faber's, and I want you to also just take a second, do the pelvic neutral with the back not quite on the ground, but just up a little bit. See if you can hold it, and do like the one where you hold your leg and not let it go back down. If you've had SI joint problems and you're really tight on your Faber's test, that's one of the things that's going to be contributing to it. That's also what we call a pattern that's going to start developing into a hip joint capsular pattern for you. Okay? So yeah, once you've done Faber's test, I just want you to try the simple SI joint mobilization exercise. So find neutral. In fact, even just bring up one leg, hold it, let the other leg be down. Find neutral, hold that neutral position, and now just give a little bit of contraction in that leg to push it down. But don't let it go. Okay? It's super subtle. If any of you have an SI joint that's a little bit more sensitive, you may feel that you'll feel that movement there because it will cause your SI joint to gap. Okay, while you're laying down there, see if you can do the transverse abdominis contraction by crossing your fingers over your ASIS, push in on your abdominal wall there, and now see if laying down there, can you suck in your gut without pushing out your fingers? Can you suck in your gut without pushing out your fingers? Okay, question over here. Yeah, you'd like it to be able to be, well, you want the tibia perpendicular, or parallel with the floor. So you want everything down low enough that it actually looks like your legs flat and parallel with the floor. Oh, yeah, it has to be above your knee, though, when you do the figure 4. Yeah. Okay. oftentimes these little slower exercises, you're not going to have time for your athletes to be doing that in your training room, right? You guys are pretty intense, and you got a minimum amount of time with your athletes, but it's super easy to teach them this and have them doing this at home. If they really have an SI joint problem, this really can be beneficial. A couple other things that are on here, such as like a knuckle diagonal reaching exercise. These are very subtle. It's actually, if I bring my left leg back, I'm just going to lean a little bit forward and come down just a little bit. And what it does is it causes me to do a teeny bit of rotation in my lumbar and force the sacrum to move just a little bit. But I'm not doing like this. I'm not doing full ground ones. We're going to talk about why that's not good for the lumbar area. These are very subtle exercises. You can go on the internet, do a ton of like little SI joint. There's quite a few PTs, chiropractors that have come up, and you'll find there's some common exercises that exist for SI joint mobilization. Okay. All right, low back pain. Let's get to the key thing. Incredible. I always go slower than I'm supposed to. Okay, we're going to skip forward here really quick. Low back pain is probably the most common problem that we find in the U.S. Huge problem in the workplace. Can be a huge problem for athletes, right? I mean, this is one of the most costly aspects of medical care that actually exists, is low back pain. Most of you are going to experience it in your life, okay? And it can be pretty serious. So what do we see in athletes, though? Well, in athletes, we got to kind of figure out what's going on. So really, is it acute, or is it something that they're chronically coming in with? That really is where you need to start getting in and figuring out and having the medical team figure out what's going on with this person. There's a couple really important things I want you to understand from low back pain, okay? There are some kind of more common diagnoses that can exist here, and we're going to run through these really quick. One's called a spondylolysis. This just means this is a Scotty dog fracture. Those athletes that do extension, serious amount of extension, like gymnasts, okay, are at more of a risk of this because your facet joints actually become much more weight-bearing as you go into extension. The facets close on each other and they push on each other, okay, even in the neck. And when they do that, in the lumbar area especially, we can get this fracture right here. It's called a Scotty dog fracture sometimes because when we look at the vertebrae from the side and obliquely, this is the spinous process. This is the transverse process right here. This is our superior articular facet that's joining with this other facet joint right there. And this is the inferior facet joint. And notice it has the outline of a Scotty dog. And so when it breaks the neck, that's called a fracture of the pars interarticularis, which is known as a spondylolysis. Okay? When that happens, you then have some instability in the spine. Now, interestingly, in the younger population, there's a German study that actually reported that you get someone with minimal displacement on this, within 3 months, they usually will be asymptomatic and able to return right back to normal play. Okay? But if you push them a little too far, you increase that displacement distance. And that can lead to something that we call a spondylolisthesis, which by definition just means one vertebrae slipping forward in relationship to the vertebrae below it. Okay, so look at that L5 segment in relationship to S1. You know, as part of a good portion of that L5 segment is way forward on that S1 segment. Okay, that's going to end up potentially causing, if that gets too bad, a lot of nerve root irritation within the segment right there. The more it displaces, the more it's going to pool within that neural canal. Okay, so that's what a spondylolisthesis is. And, you know, about 50% of these are usually due to a pars interarticularis, but you can have a spondylolisthesis with totally intact facet joints and no fracture in the pars. That oftentimes that's just related, what we call a congenital-based problem, or it's related to degenerative facets, especially as we get into an older population, and it represents what we call segmental instability. Okay, facet impingement is a thing that I've told you is probably one of the most common causes of acute back pain in your athletes, okay? Now, remember, I'm talking about acute back pain, okay? So this is the kind of movement that they go into. It's just like it was with, you've experienced with a neck before. But they go down, they're helping someone shovel snow in the winter if you're in one of those areas, or they're doing an activity, they come up, they pinch, you're like, oh my gosh, that is just hurting. And this can be bad enough that literally they can't stand up on their body. I mean, this is why so many people go into the emergency room, oftentimes is facet impingement, and having really bad spasm in the low back and the inability, or to kind of do this funky little shift walk and hardly be able to stand is actually pretty normal. What we really care about is, can you feel everything normally in the legs? Do you have any loss of sensation there, or you can suddenly not dorsiflex and plantar flex your foot? That's a problem. Just the local back pain here, that's totally normal. You'll go to the emergency room and there doesn't be, it's just acute back pain. Here's some muscle relaxants, and here's a little pain pill for you, and it'll get better, and it will. It'll resolve pretty much on its own within a few weeks. Okay, but it is very, very common. When that facet joint opens up, I'm going to escape out of here because I know I had the thing pulled up here. What can happen is, oh man, where's the one that, was that one from the other class? All right, I got to go back into here. All right, there we go. Okay, so when this facet joint opens up, you don't need to hear the thing. So here's a capsule that actually encloses this facet. So when we flex and extend, this facet joint actually opens and closes. And this is a diarthrodial joint. So what happens is inside that capsule is this blue part that's, is that not showing? Oh. How come that's not showing up there? All right, let me go. Dang, I can't get this thing working. So I'd have to close this out or something?
You probably can't use Presenter's View.
Oh. Okay. Well, let me go into normal view then. Oh, won't do that.
Let me take it out.
It's okay. Let me just go back onto this picture right here. All right, so I'm gonna have to show you from. Oh, now it's not working at all. What happened here? That up again? Okay. All right, so this spot right here, this is a facet joint, okay? And it actually has a joint capsule. You guys know, anybody popped a knuckle, you've seen your joint capsule swell up here. So when we have facets that open up, that joint capsule stretches out, but it has a synovial lining. So sometimes when it closes, it can catch that synovial lining and it'll swell up. And now that facet will either get stuck in an open position or it'll get stuck closed. That's part of the mechanical nature of the back pain. Okay, that's why your neck hurts so bad. When you twist it and you pinch, you're like, oh, that bugged me. And then now 12 hours later, you're like, oh, that is really hurting. That thing has had time to now swell up. And now it won't open and it won't move correctly. And it's painful, and it causes all the muscle around it to spasm a little bit. So facet impingement, really common. Facet joints are really important for guiding motion. That's the key thing that I want you taking from this. They have to help guide the right kind of motion. And so if that facet is inflamed and that capsule is inflamed, it's going to hurt to move that facet. Facet joint pain can be pretty serious. Again, one of the most common acute problems that I've found with someone, and it will go away. It can go away on its own. If you've got an athletic training team that knows and a chiropractor there doing a good amount of like subtle mobilizations rather than just manipulations, you can help facilitate a little faster return on it. Tropisms are something that I told you, that's what happens when we get abnormal or asymmetrical facet joints here. If you've got an athlete that has this chronic back pain that's in there and they haven't been able to figure out what's going on, we've found that in somewhere between the 30 to 50% of population will have an L5S1 that's slightly off. And the more it's off, the more it relates to one-sided common facet-based problems there, which can be a kind of a chronic type of feeling for pain. Okay. This gets us into the disc. Now, you guys have heard of disc problems. The disc is really made up of three main components. So when we look at this picture right here of this disc, we have these outer annular layers. We have a nuclear layer, which is kind of the gel-filled center. Okay? And then we have another part of the disc that's actually attached to the vertebrae. It's called the vertebral plate. Okay? So when we talk about a herniated disc, how many of you have heard the term slip disc? Okay, never use that term. Okay? Discs don't slip. So, you know, when you see something like this in the office, that's not going to happen. They're not a bar of soap. They're not just going to, there they go. Okay? Discs, they're stuck in there. They're stuck to that vertebral end plate, and they are pretty well fixed. They're immobile, really. What does happen, though, is we get degeneration of a disc. So when we take those three parts of the disc, the outer annular layers, which is actually made up of about 20 concentric rings, okay, and then we have this nuclear gel-like material in the inside, it's attached top and bottom to the vertebrae by that hyaline cartilage plate. Okay? So what happens with a disc? Well, we got to consider what are those three parts. Why do we have a nucleus pulposus? This is really interesting because most people don't understand the mechanics of this. So remember, the vertebrae itself is actually your shock absorber in your spine. The discs help to make mechanics of movement as we go from flexion to extension a little bit more normal and allow us to get that range of motion and movement in the spine. Okay, so what happens is the nucleus pulposus, which is really interesting, this is a gelatinous material. It's not like a liquid like water. It's a very thick gelatinous substance. And early on, it has a high amount of what we call proteoglycans, which is part of these glycosaminoglycans, which means they can actually absorb water a lot. So in a younger disc, they have this really good process of what we call imbibition, which is the ability to retain fluid and soak up fluid. Okay, so younger discs actually have much more water content in them than as we get a little bit older. Okay, so when we start getting, as we get older, that the properties, the ability of those proteoglycans to imbibe and suck in fluid actually decreases significantly. So we lose water content as we age. Okay, the nucleus pulposus functionally, it helps transmit forces as we kind of move around. So it's kind of like a ball bearing. It's kind of like if I have one vertebrae here and one vertebrae here and I'm sitting on an intervertebral disc, this nice little ball that's kind of sitting in here. I'm going to use this cup. I'm going to spin it. Right here. What ends up happening is as I push forward, it actually will force movement back, but it creates this rocking position around that gel-filled center. so that as I come over the nucleus, I don't just get compression and get that thing just squishing backwards. I do get some of that if I put enough force, but I come over and it helps kind of this rocking motion of one vertebrae over the other. As it does that though, like when I go into flexion in my low back, I'm going to come down, I'm going to compress the front, and I'm going to expand the back. The backside is going to stretch because it rocks over that nucleus material, okay? And it doesn't just simply push it back. It actually will stretch the backside and compress the front. And then as I go into extension, it'll compress the back. But in doing that, it means I stretch out the annular stuff as I go into flexion, and then I come back into extension, and now I squish the annular stuff. And I go into a flexion, and I stretch the annular part of the disc. Over time, we find that it's the annular walls that give out, and that's where the nuclear material starts to move, okay? This is a really interesting picture. I'm hoping you can see it pretty well on here. Notice this really jelly-looking material here in the disc, right here. This is actually on here from a late teenager, okay? This is the nuclear material. And then notice how milky white this material is in somebody that's just in their later 20s. We're already getting significant change here within the disc material of just a 10-year age span. Okay? Interesting that the discs usually lie in the center of the vertebrae, but in the lumbar they are more towards the back. Okay? And that's because we tend to take these seated postures that you're doing and we tend to force that material more towards the back. And so all of those annular layers on the backside, closer to that gel, there's 20 layers there, but notice they're super compressed. And they start to actually break down and tear, and that's when we start getting a bulge in the outer wall of the annulus. The annulus is really interesting because it's made up of multiple layers, and they're offset to each other by 60 degrees. Super helpful in helping with shear and rotational force between vertebral segments. But again, they can kind of tear layer by layer, and that nuclear material can start moving towards the back. So this is the stuff I just described to you on forward bending. The vertebrae rocks over the nucleus. And gradually over time, we break down these annular layers. And we get that nuclear material shifting backwards. And if you've ever seen an MRI of a disc, this up here, this is a nice, healthy, gelatinous-based nuclear material that we'll see. It shows up nice and white and ovally here in the MRI. And then as we get degeneration and we get older, notice we start getting darker and darker in our weighted imaging here for the actual for the spine. And notice over here on this side, I mean, this is basically just going with age, and this down here is more of a degenerative spine. And you'll see that nuclear material almost doesn't exist anymore in the spine. As we get older, this is what happens to us. So it's just kind of natural to start getting more low back problems as we get older. Let me ask you a question. What do you think is the most detrimental movement for a disc? Exactly. Okay, good, Clement. It's flexion and rotation. Flexion with rotation, okay? So one of the things that happens with movement is we get what we call intradiscal pressure. And with intradiscal pressure, positions really can increase discal pressure. So if I start flexing at my spine at all, my disc pressure goes up like crazy, okay? If I have a weight and I flex forward, my disc pressure goes up even more, okay? So take a look at that chart. So what should you gather from weight exercises with your athletes just from this chart right off the bat? Neutral spine as much as possible, okay? If you don't have to be bending over doing a weight exercise, don't do it. the interdiscal pressure goes up like crazy. Okay? And what else? Look at the far right of that slide. Notice seated positions, just by a seated position on its own, increases disc pressure a lot. Just sitting, you're at way more than you are if you're standing in the interdiscal pressure because of the mechanics of how your weight is loaded on your spine. Okay? So, seated weight training exercises, don't do them if you don't have to. Okay? It's much better for them to be on their feet than it is in a seated position, especially seated and flexed over. Interdiscal pressures increase a lot. So notice this. This is a quick chart right here. Bending forward, we're going to get up to 150 measured at L3. If we just have them slightly bend forward, we're at 150%. If we have them holding a 20 kilogram weight with the back bent and knees straight, 170% of their body weight with the external load. Okay? And we can get well above 200% if we bend forward enough. So let me ask, I put this picture on here because I wanted you to think about this with your weight room. What's wrong with this picture? Why do we do this? Someone give me an idea. What's wrong with this picture? Heaviest weight's on the bottom. And that's exactly what's wrong with this picture. Why? Let's put the heavier weight right at literally their grab height. Okay? Rather than keeping them bending over to pick up the heaviest weight. Okay? Those power racks are stable enough. They're not going to fall over with their heavier weights a little bit higher on the rack. Okay? All right, intervertebral discs get huge compressive loads on it. And one of the things I'm going to talk about here is the importance of ab. We're skipping forward a little quick because I wanted to get into some of these exercise things. Take a look at this. How many of you have used an ab wheel before? Quite a few of you, okay? You ever had your athletes go, that kind of hurts my back with an ab wheel? Why? Okay, it doesn't solve the problem. Right, so what happens is they're just going too far. I mean, the problem with getting an ab wheel is like, I don't want to look like a pansy, so I got to go all the way down, right? And you have no stability on that thing, ab wheel going wise, and you got body weight pushing on you, but they go past the point that they can stabilize. Okay, they go past the point they can stabilize. If all they can handle is just going halfway, pelvic neutral is always the starting position, and then you move out the hips first and then start moving towards the arms. Okay? Only go as far as there's no back discomfort. That means they're moving out of pelvic neutral and they're collapsing in their back. If your abs can't control the spinal motion, your back compresses and the pain is there. Okay? It's a great exercise, but they have to do it within the motion they can control. Okay? What about the guy in the middle right there? Side bending dumbbell exercises. Okay? Oblique exercise, right? Good or bad? Don't give me the answer I want to hear. Give me the answer. What do you think? You think bad? Why? Yeah, so this is just side bend. This is a vertical load that you now take a spine out of neutral position and then both side bending and rotation always occur together in the spine. You never only side bend. You side bend and you rotate. Okay? Those two motions always go together in the spine, which means that's moving us towards a position that is not good for interdiscal pressure. It's terrible for interdiscal pressure. Somebody who has a low back problem, give them a whole set of those to do. And the next day, they will tell you that they are going to be hurting like crazy. Okay? All right, what about planks? Right here. Good or bad? Can be really good. I mean, this is a great static exercise if they can maintain body weight. Okay? If they can maintain body weight and it doesn't bug them, definitely have them do planks. If they have generalized low back pain, that's a great little start. If they can't do that, we could modify that and have them go up on a ball, okay? because you can shorten your lever arm by putting their feet up on a ball. Okay? So you can actually work towards plank, but again, what's the key? What position do they have to be in for any of these exercises? Pelvic neutral. Get them there and get them being able to activate their transverse abdominis. Now here's my big thing I do with my students at school. I talk about this one right over here. So what's this called if we only go up this far right here? What's that exercise called? It's, sorry, you guys can't see that probably pretty well. If I only come up halfway, what do we call that? We call it a crunch. If I go all the way up to my knees, it's called a sit-up. What's a sit-up good for? Okay, good for strength. But man, it is a hip flexor workout. Like crazy. It is a massive hip flexor workout. It is not an abdominal workout. Your abs will work isometrically, but once you get your shoulders off the floor, your scapula off the floor, your abs have done all they're going to do. Okay? Now, here's the big question, though. Let me pull this chair over here. Okay, I want you to get an appreciation of this. You guys have already told me hip flexor is the most common problem in the low back. Let's pretend this is somebody's upper half of their body. Okay, the back of the chair is their head. Here's where their spine meets into their pelvis right here. Hip flexor, psoas major, originates from the lower 5 lumbar vertebrae, basically. Okay, the bodies and transverse processes of L1 to L4, sometimes 5. Okay? So, hip flexor is going to pull up the body, literally. Psoas major, if we're doing hip flexion, it's literally like you having to take this chair and crank from the lowest segment to pull that thing up. What do you think that's doing to disc compression in the low back? Huge lower back disc compression because the leverage is all the way here from the bottom to pull the entire upper body upwards. Okay? Take anybody that has any significant amount of back pain, and that is the last thing in the world they're going to want to do is a sit-up. Not to mention the incredible amount of disc compression that occurs there. You guys saw this out here in the event over here. Is this good or bad? So let me give you thoughts. I ran 10 people through that were low back pain through this. This is one of the things I actually think this would be beneficial for. Actually is people with generalized low back pain that have with vertical loading, we have much more compression spine-wise. One of the great things about doing like planks and other things is we actually take the vertical load of overall mass out. So planks are great. This is not, I've heard some people say, oh, it's an ab wheel on steroids. It's not. One of the things that's really cool about this is that it actually has weight that you can add, and so if the weight's there, you get compression that actually pushes you in. So I found with some of the guys that I tested on this that had generalized low back pain, if I matched just the right percentage of weight on there, they could go down and do the full movement without any low back pain at all. And what's really kind of cool is watch the guy up on top there. He goes up a little too far. I wouldn't take a back pain patient that far, someone generalized. But if they keep their leg movement not all the way to the point where it hits the thing, they can actually maintain a really neutral spine through the entire exercise. And you can get overall leg loading that's really high without back pain. And that's why I took them through a whole week of stuff thinking, wow, this has some potential on that side. And I think there's great potential there for low back pain patients to get some resistance exercise in on there. And have to stabilize their core. Okay, so let me go up here. Sit-ups, I'm just going to tell you right now, sit-ups are terrible. Okay? I'm going to go to a couple other things that I think are problematic. Bicycle crunches. I know everybody has someone doing these, okay? What is the problem with bicycle crunches, okay? The problem is you're having them rotate and we're getting the pelvis doing this motion. And the back actually loses stability when you move it between flexion, extension, and rotation fast, especially, okay? So that's bicycling, really a big problem. Plus, it's still mostly hip flexor. Yeah, we're trying to control the pelvis a little bit, but honestly, I would go to a lot more of the planks and crunches, much more so than I would having this dynamic motion. Here's one of my biggies right here. Oh my gosh. And you'll understand this when you start getting your own back pain. That's starting to be significant. As far as intradiscal pressure goes, this just goes through the roof. And we just said being flexed and rotated over is the worst position for the disc. Okay? Russian twists or V-sits and rotations. First of all, that's not a functional movement anyway. When are we ever stuck athletically in that position? Okay? But the amount of load on the back is just terrible. Okay? It is huge. So this is a much better option right here, where this lady's on a ball and rotate over. Not only for this, not just for rotational control, but also for the fact that we can work on thoracic mobility as we do this. Okay? Move that ball a little bit more forward and we'll actually force mobility in a different part of the thoracic spine. This is a much better position, or even standing cable rotations. Those are great also. Okay? You're not vertically loading with the extra weight. But that V-sit and rotation, please avoid. This is like my little sarcasm note. Here, let me hand you my nucleus pulposus. I won't be needing it anymore. Okay? You keep doing those, I guarantee you that will be your case. Okay? Here's the other one I think is hugely problematic. We have throwing activities. As long as you keep that throwing activity in the front, okay for power. But don't do hundreds of repetitions. Plenty of studies out there showing a complete loss of segmental control once you start getting any fatigue setting in those back muscles. Okay, so power muscles, keep them short on their number of reps. Don't be having them do hundreds of these. But anything going backwards or any throws to the back, please avoid. If you're going to throw out, but make sure the rotation stops here before it becomes backwards. Then it is actually a pretty good exercise. Okay? All right. Overhead squat. I know in this population, you'd like to crucify me. But let me ask this. Terrell, I saw you over here. Why do you do the overhead squat? Perfect athletic movement. For what? For an athlete? Okay, give me more. Okay, it is. I'll agree with that. Good range of motion assessment tool. That's why my thing, you should not have anybody doing this unless they can score a 3 on your FMS test. Okay? Where we get problem, now here's where the problem exists. The problem exists in people that have a range of motion deficiency. If they don't have really good flexibility in there to be able to get to this position, they shouldn't be doing it. So I'm not saying don't do this. I'm just saying look really carefully at the ones you're having do it. And if they do not have the full range of motion to do this, it stresses out. First of all, shoulder, bad. But it really stresses out the thoracic spine and can lead to some problems there. Okay? So I want you to just take a look at them. Where's that humming coming from? Oh, somewhere else. Okay. Take a look at that one. This is only problematic if they don't have the range of motion on there. All right, Romanian deadlift. How many of you do this? I love this exercise when I was in the training room. Okay? Back position is so key on this one, though. Make sure they are maintaining a stable back. Okay, when you're having them do this one. There really is no need to do this heavy, however. This is kind of the machismo thing that I would really like to see changed in the weight room. You can get awesome isolation and awesome hamstring work with lower loads than what usually people are doing with this thing. okay? And there is no reason to have an isolated hamstring work super heavy with this, because the hamstrings don't normally work in this fashion. Having to pull up and do excessive amounts of back extension loaded in almost any sporting activity. Most of ours is a pushing activity forward. We're not having to lift a bunch of people off our back. Okay? So keep it a little bit lower, and then we really reduce the intradiscal compression that's going to occur with this lift. Okay? So my thoughts on this is more towards, it's great for athletes, but keep it minimal, because eventually those athletes have to live their lives and do business later in life, right? So we really want to get ingrained in them a way to do things that are not going to tear down their back and just worry about that later. Right now, as an athlete, I just need this from you. Help them have a great future, okay? Understanding discal compression and how these loads can actually affect that is really important. All right, Romanian back lifts, back extensions, pretty decent if they're done well in good forms, and there are alternate forms to do. If you have any questions on some of these lifts, I'm more than willing to talk with you about some stuff. I really want you to understand pelvic neutral and the effect that those loads can have on intradiscal compression. So, thanks for your time.